I'm honored by this opportunity to talk about the medical applications of laser for an August audience, which include physicists and non-physicists. For the benefit of non-physicists, let me explain the basics of laser. In the beginning of the 20th century, people know about the spontaneous emission of radiation in the form of photons. And Einstein in 1916 postulated that stimulated emission of photon is also possible. What is the difference between spontaneous emission and stimulated emission? When an atom is excited by an external energy, it spontaneously emits a photon and return to the ground state. When such a photon passes close to another identical excited atom, it can stimulate this atom to emit a photon that's an exact replica of the incoming one. When more and more atoms are in the excited state than in the ground state, what we call a population inversion, then more of this photon will come near excited atoms and causes stimulated emission. So this process become amplified. So that's why you call light amplification by stimulated emission of radiation. So what we are achieving is an amplified emission of radiation. So laser has mainly four properties. It is collimated, which means it's parallel rays. It's unidirectional. It's monophasic because all the photons are in the same phase. Their energy adds up. And it is monochromatic, which means all the photons have the same wavelength. Effect of laser on the tissue depends both on the tissue as well as on the type of laser used. The tissues absorb laser differently. So for a laser, the chromophore is the tissue which absorbs that particular laser very well. For example, for near infrared lasers, the main target chromophore is hemoglobin in the blood vessels and melanin, which is a skin pigment. For carbon dioxide lasers, the only chromophore is water. So if you want to get a selective photothermolysis, for example, of the melanin, you have to use a laser which is mostly absorbed by that melanin and no other tissue. So here I'm discussing about the four chromophores in skin. One is oxygenated hemoglobin, the other is deoxygenated hemoglobin, melanin and water. On the y-axis, you can see how much laser is absorbed by the tissue. And on the x-axis shows the wavelength of the laser. For oxyhemoglobin, it is absorbed maximum in a low wavelength, and as the wavelength increases, the absorption of the laser also decreases. The same with the deoxyhemoglobin and melanin. On the contrary, there is no absorption by water of any laser of wavelength less than 1000. As the wavelength increases from 1000, the absorption reaches a maximum at a wavelength of 2940 for water. So this principle is mainly utilized for lasers used in body because 75% of the human body is made of water. There are two important aspects of effect of tissue. One is the penetration of the laser, and second is the energy density. Because laser can be focused, so it can increase the density of the laser. So when you look at the tissue penetration, the graph shows that as the wavelength increases, the tissue penetration rapidly increases and reaches a plateau. And then the tissue penetration gradually drops. So excimer laser, which is an ultraviolet laser, has very low tissue penetration. Whereas a ruby laser has a large tissue penetration. So, for example, skin is divided into epidermis, which is the pigmented area, and dermis, which is below. Excimer laser and carbon dioxide laser, they don't go below the epidermis, whereas sapphire lasers go up to the dermis. So there are mainly three different types of laser tissue interaction. One is photothermal, that is a heat effect. Second is photochemical, a chemical reaction. And third is photomechanical. Photothermal effect depends on the temperature. At temperatures between 40 to 60 degrees centigrade, it causes mainly denaturization of the protein. We call it coagulation. So mainly krypton, argon, and diode lasers are used for this purpose. When the temperature reaches 100 degrees, the water in the tissue vaporizes. So along with the water, the tissue also vaporizes. And this helps to seal the blood vessels, and you get a bloodless field. Photochemical reactions are of two types. One is called photoradiation. Here, a sensitizing agent is applied on the surface of the tissue, or we give it as an intravenous into the vein. So that photosensitizing agent is absorbed by the target tissue, and you expose it to a laser, usually a red laser at 690 nanometer wavelength. This induces the formation of cytotoxic reactive radicals. I'll explain it in more detail later. And second is photoablation. Here what happens is, if a very powerful laser is used and this strips, so this splits the bonds between long chain carbon hydrocarbons in the body, and therefore it vaporizes the tissue into small bits. So this is called photoablation. A typical example is the excimer laser. Photomechanical ablation is also called photoionizing or photodisruption. Here, even higher energy laser is used, and this laser strips electrons from the molecules, producing microplasma. So this has got a very high temperature, up to 20,000 degrees centigrade, but this is only applying only a small area. So there is no damage to the surrounding tissue. Photodisruptive or photomechanical effect is mainly used to break the stones, like the kidney stones or stones in the biliary system. And also, it is also used in ophthalmology. The last, but probably not important effect, is what you call biostimulation. This happens at very low energy, and it does not injure the tissue. It is supposed to stimulate the tissue, and there are several applications to it, but there is still a controversy whether the effect is real or not. So I'll summarize the 6 effects of laser on the tissue. At high energy and low wavelength or high frequency, you get electromechanical effect. Slightly more higher wavelength, you get ablation. Still higher wavelength, you get vaporization. That's about 100-degree temperature. And still lower temperature, you get coagulation. Still lower temperature, you get photochemical effect. And least temperature, you get biostimulation. Commonly used lasers start from ultraviolet to the far infrared. Commonly used medical lasers classified into 3 groups: solid state lasers, gas lasers, and others. From each group, I will give 3 examples. Ruby laser. This is the first laser made by Theodore Maiman in 1960. And it was used to remove a skin cancer called melanoma. In 1964, this laser was also used for photocoagulation of the retina. Currently, it is mainly used to remove tattoos and hair. The next milestone in laser development was ND-YAG laser, where 1 to 2% neodymium is doped into yttrium aluminum garnet crystals. And this lasing medium is excited by flashed xenon lamps, or more recently by diode lasers. The most common wavelength used is 1064 nanometer. It can be both pulsed or a continuous wave mode. In order to get ultra short pulses, a process called Q switching is used. It has got good penetration up to 3.5 millimeter. KTP laser is a variation of the ND-YAG laser. Here, potassium titanium oxide phosphate crystal is placed in a beam of ND-YAG laser, which has got a wavelength of 1064. So its wavelength is reduced to 532. The advantage is, at a lower wavelength, it has a more better coagulative properties. It is a green laser, so it is well absorbed by hemoglobin and therefore is used to treat vascular, means blood vessel lesions like angioma, rosacea, and port vein stain. Port vein stain is the type of skin lesion seen in Gorbachev. Everybody will be familiar with that. It's also used for photoselective vaporization of enlarged prostate. In holmium laser, instead of neodymium, a rare earth holmium ions are used. It emits energy at 2100 nanometer wavelength. It offers precise cutting with minimal damage to the adjacent tissue. So it has a wide range of applications: urology, laparoscopy, neurosurgery, and stone cutting, angioplasty, and orthopedic surgery. Commonest gas laser is carbon dioxide laser, which was the earliest one to be made. So it's a mixture of helium, nitrogen, and carbon dioxide. So the laser medium is excited by electrical discharge. It has got very high efficiency. 10 to 15% of the input power is converted to laser. The only disadvantage is it cannot be transmitted to optical fibers. So you need to use a different mirror system to take the laser energy inside the body. Another point is, because it's infrared region, it cannot be seen, and therefore we have to use helium neon lasers to generate aiming beams along with the carbon dioxide laser. So this is how the carbon dioxide laser works. It can be used as a scalpel, right, as a knife. So when it's a very focused to 100 micrometer, it cut the skin. And you can excise a skin lesion using the laser scalpel. And suppose you have to remove a superficial lesion without cutting, you can use a slightly less focused beam with a 300 micrometer size, and you can vaporize the tissue. Suppose there is bleeding, what do? You increase the beam size to 800 micrometer, and therefore the temperature drops. So instead of vaporization, it causes coagulation and stop the bleeding. So in this picture, you can see from the point of impact of the laser, along concentric circles, the temperature drops. So at the point of contact, there is a tissue vaporization. Little away from that, there is coagulation. And further away, you get tissue denaturization. And at the very periphery, you get biostimulant effect. Another gas laser is the argon and krypton ion lasers. These lasers need to be ionized to produce the laser light. They are not very efficient and therefore not much used. The advantage is they can be transmitted through optical fibers. And since it is absorbed very well by hemoglobin, it has got excellent coagulative properties. For example, it can be used to stop a bleeding peptic ulcer. It also is used for vaporization of pigmented lesions in the skin and retina. Excimer laser comes from the word excited dimer. So what is this dimer is made of? Two atoms, one of two noble gases like argon, krypton, or xenon, or you combine an atom of rare gas with a reactive gas. So you get a noble gas halide diatom. So this is excited using a high energy, 10 electron volt energy. So it becomes temporarily excited. And the excited state is not stable and releases energy, either spontaneous or stimulator emission. This stimulator emission is used to make the excimer laser. Because it's a very ultra short, lasting only nanoseconds, it doesn't generate any heat. So it's a cold surface laser and also just very little tissue penetration. So the advantage is you can cut thin slices from the surface of the skin or from the surface of the cornea without any damage to the surrounding tissue. Other commonly used lasers are, one is dye laser, where a lasing medium contains a dye. And dye lasers are mainly used for photodynamic therapy, which I'll explain later. Diode lasers uses the same principle as an LED light. The only difference is LED light is not monochromatic, whereas diode laser is monochromatic. Most of the lasers are pulsed lasers. Continuous wave lasers have very little application because they can cause more thermal damage. So if you want to use minimal tissue damage, use a pulsed laser. How does laser work on tissues? As I say, you can apply laser on the surface, which is skin or the cornea of the eye. But most of the times you have to use the laser inside the human body. So it needs to be delivered through a fiber system. And it can be both contact or non-contact. So it can have an optical effect, a thermal effect, or mechanical effect, I explained before. So there are different types of probes available. So I would like to broadly divide the use of laser into diagnostic purpose and therapeutic purpose. Normally in an endoscope, use xenon light, which is a white light. The problem with that is the red component of the white light is absorbed by the mucosal surface without being reflected, preventing detailed image of the mucosal surface. And also, when the light goes through the different levels of the tissue, it is scattered with a different degree, and therefore the returning light will have less resolution. So in order to increase the resolution of the returning light, we can use a monochromatic laser. Usually 410 and 450 nanometer wavelength is used. We can improve the resolution even further by using a magnifying endoscope. Let me show it using pictures of chronic gastritis. What is chronic gastritis? It's an inflammation of the lining of the stomach produced mostly by an infection with a bacteria called Helicobacter pylori. Why it is important? Because chronic gastritis can be of different types. For example, if there are 1,000 people with the chronic gastritis, 10% will develop what you call intestinal metaplasia, which means the stomach lining modifies into intestinal type of lining, which is a pre-malignant process. Out of 100 intestinal metaplasia, 10% will go to atrophic gastritis, which means the cells lose the normal morphology. And these cells can turn into what you call dysplasia or cancer. So a tiny proportion, say 1 in 1,000 of chronic gastritis can turn into cancer. So these subtle changes cannot be picked up by normal endoscopy. As you can see in picture A, the picture is quite blurred. So if you increase the resolution, you can see slightly better as you've seen in picture B. Whereas if you want to see true details of the mucosa, you can use a blue light. And in picture D, you can see the very great details using a magnified blue light microscope. A further development in a diagnostic endoscopy is the use of confocal laser microscopy. Normally, we take a tissue sample when we do endoscopy and look under the microscope, but we call it biopsy or histopathology. The idea of this system is to do the same thing using laser. So here, the illuminating light laser and the returning laser or the detecting laser go through a slit. So this gives the light from different layers of the tissue a more resolution. So this confocal laser endomicroscopy, otherwise optical biopsy, can be used by two methods. One, a miniature endoscope is attached to a normal working endoscope, and a blue laser of wavelength 488 nanometer is used to make different slices at a high resolution. It goes up to a tissue depth of 250 micrometer. Or you can use probes. These probes can be passed through the working channel of a normal endoscope. So depending on where you want to use the probe, different size of probes are available. Use a different wavelength, 499 blue laser is used. And often a contrast is given so that it will give a fluorescence and the tissue diagnose even better. You can see the baby confocal endoscope is attached to a normal endoscope. So this In picture B, you can do a normal tissue biopsy, which is stained by eosin and hematoxylin dye. The same picture you can see on optical biopsy, very similar. So what, I think I have to show this one first. So why it is important is because in the lower end of the esophagus, due to acid reflux, the lining changes from what you call squamous epithelium, which is pale, to a pink color, which you call intestinal metaplasia, which I already alluded is a precancerous condition. So it is important to know when there is intestinal metaplasia. You can diagnose it from the color, but even better, in optical biopsy, you can see the columnar lining of the lower end of the esophagus, and you can see the blood vessels in the submucosa. And in the next picture, what happens when it changes into cancer? That organization is lost. The cells becomes very irregular, and there's a corresponding change in the lining. You can see the intestinal metaplasia or Barrett's esophagus has changed. However, an optical biopsy will confirm it, and you don't need to take a biopsy. If you want to do corrective treatment, for example, submucosal resection of an area of Barrett's esophagus, you can do it at the time of the endoscopy. So you can save time and repeat the endoscopic procedure. So surgeon has 5 tools. One is the ordinary knife. You can use radiofrequency electrosurgery, high frequency ultrasound waves, cryosurgery, and laser. So clearly knife is the cheapest, and electrosurgery is widely available and is cheap also. Ultrasound, cryosurgery, and laser are used only in special cases. Laser is a good application for skin lesions because we got 3 different chromophores: oxyhemoglobin, melanin, and water. So you can use different lasers to target these three chromophores. So the lasers used are pulse dye, ruby, KTP, diode, and also infrared wavelength, carbon dioxide, and Nd:YAG. So mainly used for blood vessel lesions like hemangiomas, port vein stains, angiofibroma, and benign and malignant skin tumors such as basal cell carcinoma, congenital melanocytic nevi, hypertrophied scars, tattoos, and excess hair. So these are some pictures. Here you can see infantile hemangioma, ulcerated infantile hemangioma, angiofibroma, port vein stain in a child, port vein stain in a slightly older body. This is AV malformation, hypertrophied scar, and residual lesion after treatment. This is common wart. All these lesions can be treated by laser. This is a picture of port vein stain in a young baby. So how you treat port vein stain? You can use either a pulsed dye laser, which is absorbed by hemoglobin, and it targets diseased blood vessels selectively without affecting the surrounding tissue. And it incorporates a cryogen cooling spray to protect the epidermis while during the treatment. Another method is photodynamic therapy. I'll come to that later. Photodynamic therapy. So in the body, succinylcholine, coenzyme A, and glycine combine to form aminolevulinic acid, which is converted to photoporphyrin 1X. Photoporphyrin 1X is a sensitizing agent. So protoporphyrin 1X combined with the iron to form heme. But ferrochelatase is a rate limiting enzyme. So only a limited amount of protoporphyrin IX can be converted to heme. So if you give ALA from outside, this will cause accumulation of protoporphyrin IX in the tissue, which cannot be converted to heme. And this especially happens in tumor cells when there is a rapid division of cells. So you then apply a laser at 613 nanometer. This laser is absorbed by protoporphyrin IX. And it has two properties. It will give a fluorescence, so you can know where the cancer cells are. And also, it induces the formation of cytotoxic oxygen-free radicals, especially singlet oxygen. This is unstable and it releases its energy and destroys the cell. This is what you call basal cell carcinoma. It's a cancer of the skin. So it's a methyl ester of ALA is applied on the skin, and they use a laser to view the fluorescence. So you have to use a laser to see this. The advantage is you can see the extent of the lesion, how far it is going into the skin. The laser itself kills the cancer cells, and also once you know how much cancer cells are there, you can use a carbon dioxide laser to excise the lesion with a margin of normal tissue. In ophthalmology, the main use in refractive errors. There are three types of refractive errors. One is myopia, when the eye is small, so the light is focused behind the retina. In hypermetropia, in myopia, the eyeball is large, so the eye is focused in front of the retina. And in hypermetropia, the eyeball is small, so the light is focused behind the retina. So in both cases, there is blurred images. So myopia is corrected by placing a convex lens in front of the eye, or you can surgically flatten the center of the cornea. In hypermetropia, use a convex lens, or you increase the curvature by steepening the cornea. In astigmatism, different areas of the cornea has different convergence. So you can either flatten the cornea or steepen the cornea, depending on the situation. The commonest technique used is called LASIK, laser-assisted in situ keratomiliosis. So I already explained, it flattens the center of the cornea in myopia, and it removes a mid-peripheral ring of cornea to cause the center to protrude in hypermetropia. So patients, anybody over the age of 21 is suited for this treatment. Procedure. A hinged partial thickness corneal flap is cut by a micro knife or a microkeratome or a femtosecond laser. The flap is then folded backwards and a pre-programmed eczema laser ablation is carried out. And the flap is replaced and held in place with a soft contact lens. So to cut the cornea, you can either use a microkeratome or a femtosecond laser. The laser is better because it gives uniform thickness flap. However, it's more expensive. I'll show the other two techniques in the next slide. So here is the picture of the cornea, and the pink thing is the epithelium, and the red one is the corneal stratum. So in the first procedure, you remove a flap of the epithelium only, and then you ablate the cornea. In LASIK, you remove the epithelium and the small thickness of the superficial part of the corneal stratum. And then this is a case of myopia where you have removed, ablated a part of the surface of the cornea with the excimer laser. So 90% success rate with the keratoplasty, and the risk of complications is only less than 1%. So both these procedures, LASIK and keratoplasty, gives good results. Another application of laser is in glaucoma. Glaucoma means increase in pressure inside the eye. So there is a fluid called aqueous humor, which is bathing the eye. This is called the posterior chamber, and this is the anterior chamber. So this aqueous humor is produced in the ciliary body, and it flows out through the pupil into the front of the eye, and then is absorbed through this area of the eye. So in acute angle glaucoma, there is a blockage and the aqueous humor is not drained. So here we use a laser to make holes in the periphery of the iris. It's called peripheral iridotomy. So we use a laser to make holes in the periphery of the iris to relieve acute angle glaucoma. In open angle glaucoma, there's a malfunction of the trabecular mesh. So you can use a laser to improve the drainage of the aqueous humor to the trabecular mesh by a biostimulant effect. Other applications of laser are in ablation of a corneal opacification from injury to the cornea or infected ulcer. In diabetic retinopathy, there may be leaking blood vessels, which can be corrected by photocoagulation. And you can also do photodynamic therapy for destroying the blood vessels in macular degeneration. So the main therapeutic use of laser is in stopping bleeding peptic ulcers or bleeding ulcers in the colon. It is also used for the palliative treatment of cancer. So for this, the photothermal effect of the laser is used. So the surface of an exophytic lesion, which means a protruding lesion into the lumen, is vaporized, and there will be blood vessels behind it, which will be coagulated by the laser. And then we normally put a stent to make a lumen in either in the esophagus or in the colon. So obstructing lesions of the esophagus or colon can be bypassed, first by removing a part of the tumor and then using a stent. In bleeding peptic ulcers, most of the hospitals use injection sclerotherapy rather than laser because it's much more cheaper and is widely available. Other use is interstitial laser photocoagulation. For small secondary tumors in the liver, you can insert a fiber under a CT scan and target the tissue and burn the cancer. And another application of laser is in PDT, photodynamic therapy. For example, in dysplasia in Barrett's esophagus, which I alluded to in the lower end of the esophagus, if you have a dysplasia, you can do submucosal resection, or you can use a dye which is selectively absorbed by the abnormal cells, and when a laser is applied, these abnormal cells are destroyed. The same principle can be used to remove small tumors in the gastrointestinal tract and tumors of the pancreas and bile duct. The advantage of PDT is that it has no thermal effect. It uses low energy laser, which is absorbed selectively by the sensitizing agent, which is usually protoporphyrin 1X. In neurosurgery, you can use MRI-guided laser interstitial thermal therapy. So what we use is a selective ablation of a lesion. It could be a tumor, which could be an abnormal active area producing epilepsy. Currently, we use radiofrequency, cryosurgery, or microwave ablation for this purpose. However, laser ablation has a superior precision up to 1 millimeter. So mainly ND-YAG laser of wavelength 164 nanometer is used for this purpose. So we use what you call a stereo tactic. It's a 3-dimensional guidance. We make a small hole in the cranium of the skull, and you pass a laser fiber induced into the brain tissue, reach the target lesion with a precision of 1 millimeter or less. Then use a sapphire tip fiber, which is cooled, to the center of the tumor using an applicator system. And you use thermal energy to destroy the tumor. So you have to make sure that this surrounding normal tissue is not heated. So use a magnetic resonance thermometry to monitor the temperature of the surrounding tissue. So this is a picture of laser being used for that purpose. So you can see a ring-enhancing lesion. It's a glioblastoma or a brain tumor. So the laser is inside the tumor, and after treatment, it has shrunk. So 4 months later, it has almost disappeared. So this kind of treatment, interstitial laser therapy, can be used for brain tumors like glioblastoma, deep-seated secondary brain tumors, temporal lobe epilepsy, and ablation of cingulum for chronic pain. So another method is photodynamic therapy. So it has got 3 processes. First, photodynamic diagnosis. So the same principle, ALA, is intravenously given, and this will produce a fluorescence, which is picked up by laser at 375 to 440 nanometer light. So first, the active lesion is visualized after giving a photosensitizing agent. So this photosensitizing agent also destroys the brain tumor by the singlet oxygen. But the destruction is not complete. Therefore, use a fluorescence. So you can already see the tumor with the fluorescence light, and then you can remove the tumor using standard technique. So this is a common condition, degeneration of the intervertebral disc. I can see the disc is protruding and pressing on the nerves coming off the spinal cord. So there is inflammation of the nerves producing pain. So there's a new development is a percutaneous laser disc decompression. It is still in the research stage. The advantage is it can be done under local anesthesia. Patient is placed in a prone or lateral decubitus position under the guidance of C-arm fluoroscopy. An 18-gauge needle is inserted. Through the needle, an optic fiber from which a laser energy is transmitted. So this laser evaporates water in the nucleus pulposus. So the disc has got a center called the nucleus pulposus and a periphery called thicker tissue. So the nucleus pulposus is vaporized. The success rate is about 70 to 89%. Heart and blood vessels. So normally for blocked blood vessels, you use a coronary angioplasty, where a balloon catheter is used to dilate the narrow area of the coronary artery. But there's an application of laser to remove the coronary adenoma. So the effect of the laser is threefold. One is photochemical, photothermal, and photomechanical. So what are the indications for using excimer laser in angioplasty? There are mainly 4 indications. One is acute heart attack, to remove a thrombus and debulk the plaque. Secondary is when the balloon fails, you can use a laser probe to remove the plaque. And also in chronic total occlusion by step-by-step removal of the plaque. And sometimes after angioplasty, a stent is put and the stent blockage occurs due to stent thrombosis. In that situation, we can use a laser to remove the underlying plaque and clear the thrombus. Other use of laser is ablation of abnormal conducting areas in the ventricle or in the atrium. So to treat ventricular and supraventricular arrhythmias, photocoagulation effect of the laser can be used. Normally, an Nd:YAG laser or pulsed argon laser is used for this purpose. Currently, most centers use catheter cryoablation or radiofrequency catheter ablation, but this can be replaced by laser ablation. To increase the blood supply to the heart muscle, you can use transmyocardial revasculation using the laser. So similar to coronary angioplasty, blocked blood vessels in the periphery of the legs can also be treated with the same excimer laser at 308 nanometer wavelength. So even though the 3 effects are there, the photomechanical effect is the most important bit. And the high energy is used to break down the plaques to smaller sizes, 10 micrometer in size. Like in the coronary vessels, it can be used to cross total occlusions by step-by-step ablation of the atheromatic plaque. For tight stenosis, a guide wire is passed beyond the lesion and the catheter is slowly advanced to the lesion and the plaque is ablated. So they claim a 90% success rate with this procedure. The application of laser in neurology is mainly 2. One is for the treatment of enlarged prostate. Mainly holmium laser is used for enucleation of the prostate. It can be very successfully used even in very large prostates. So here, the water in the prostate gland is targeted. It produces water vapor and that disrupts the tissue. And also, it is part of the prostate, it is coagulated as well. The advantage of hormone laser enucleation over conventional transurethral resection of the prostate is that there will be less bleeding. And also, they need a catheter for a shorter period of time and lower immediate complication rate. Other use of holmium laser is the resection of superficial bladder tumors and incision of ureterocele, which can cause an obstruction of the drainage of urine and urethral strictures, which is a common use of holmium laser. Urethral strictures can be cut with the knife also. Uretral lithotripsy means removal of the stone in the ureter, which is the tube connecting the kidney to the bladder. So the urine from the kidney goes through a funnel called pelvic calcium system into the ureter. So that's a site, there's a narrowing of the ureter, and therefore stones can get stuck there. So two types of lasers are used. One is a pulsed dye laser, which uses a photomechanical effect, and holmium YAG laser is mainly used for its photothermal effect. Now I'll show you a short video. This is a promotional educational video by Mestro. Here you can see a rigid urethroscope is introduced through the penis into the bladder. So the previous patient had an obstructed ureter, so they used a stent. So they have removed the stent first. So this is, they passed a guide wire into the ureter, and then so now they are passing a ureter catheter. The purpose of this ureter catheter is that it has got two lumen, and you can pass two guide wires into the lumen. Still using the guide wire. Now, so this ureter catheter has two guide wires. So they have introduced two guide wires already. Now you got a ureteroscope. This is the camera. So this camera is passed through one of the guide wires so that it's much easier to pass. They're testing the ureteroscope. Now the ureteroscope is seeing the inside of the ureter. So you can see the stones in the ureter. Now they are introducing a blue laser, holmium YAG laser. So the blue thing is the holmium YAG laser, and the yellow thing is the guide wire. Now you can see the stone in the upper end of the ureter, and the holmium YAG laser is used as a non-contact method, and the stones are broken into small pieces, and water and air is irrigated through the working channel so that the ureter is distended. It's important that the laser doesn't touch the wall of the ureter. The stones are being slowly destroyed into small fragments. So almost all the stones has been made into small fragments, which has washed out through into the bladder. There is still some stones there which are being broken. Now, so what they have done is they introduced a small basket to remove a small stone for analysis. So that is how we remove a stone from the ureter. In dentistry, we mainly use photodynamic therapy for destruction of biofilms. Biofilms are complex bacterial aggregates which are present in the plaques. So if the plaques are present over the enamel surface of the tooth gingival junction, root of the tooth, it can cause inflammation in the periodontic area and cause loosening of the tooth. So you can mechanically remove the plaque and that will cause injury to the gum. Whereas if you use a photodynamic therapy, there will be no injury to the surrounding tissue. It will only destroy the biofilm containing the bacteria. And 90% of the bacteria are destroyed. The process can be repeated any number of times. And the common lasers used are helium neon laser and diode lasers. It can also be used to treat tooth canals with Nd:YAG laser. In orthopedics, mainly is used for arthroscopy to remove damaged cartilage or meniscus. So we only remove the shreds of injured cartilage and the nature will heal the remaining cartilage. In gynecology, carbon dioxide laser is mainly used in laparoscopy to remove endometriosis. Endometriosis means there is a lining of the womb outside the uterus, and during periods, bleeding can occur into these areas and cause collection of blood. We call it endometriosis, and that can cause adhesion of the tissue and can cause pain. So these areas of endometriosis can be removed with the carbon dioxide laser. And it can also be used to treat condyloma acuminatum, which is a sexually transmitted virus disease. Nd:YAG laser is also proposed for its biostimulant effect for treatment of vaginal atrophy. But here I mainly want to talk about photodynamic therapy for cervical intraepithelial neoplasia, which is a precancerous condition and lead to carcinoma of the cervix. So cervical intraepithelial neoplasia is divided into 3 groups or 3 phases, type 1 to type 3. And type 3 is a high-grade dysplasia and can lead to cervical cancer. Normally, we only observe CIN 1 stage, and for CIN 3, normally we use an electrosurgical excision procedure, but it has got disadvantages. Therefore, if we use photodynamic therapy to destroy cervical intraepithelial neoplasia, that will be advantageous for the patient. So initially, we apply a 2-gram cream of a methyl ester of ALA over the cervix, and it produces photoporphyrin X fluorescence visualized through a 405 nanometer laser beam. And then use a 630 nanometer laser beam to irradiate this highly fluorescent area. And then after treatment, use a 405 nanometer laser to look for the fluorescence and see how much abnormal area has been destroyed. So they have this treatment twice, 1 week apart. The treatment may not completely destroy the cancer cells. So you may require to do an electrosurgical excision of the abnormal area. However, most of the abnormal area has been destroyed by the PDT. So you have to remove only much less area, and therefore damage to the cervix will be much less. So if you use electrosurgical current to cut the abnormal area, you are likely to remove more cervix, and therefore when it heals, it can produce cervical narrowing or stenosis. And if most of the cervix is destroyed, then there will be incompetent cervix. So that can lead to preterm delivery, and preterm delivery can lead to low birth weight infant. And sometimes, if most of the cervix has been removed, then it can lead to infertility due to removing the cervical factor. So here you can see the patient lying on the table, and the laser beam is applied over the cervix. And you can see the red light, this is the protoporphyrin 1X fluorescence using a red laser. And after treatment with the 630-90 nanometer laser, the red area has been completely removed. When we use laser, there are certain things we have to remember, because laser can damage the retina of the eye, and therefore we have to have a record of how much maximum laser can be used, and also everybody should be aware of a laser safety document. And during laser, all the windows are blinded, and everybody in theater should be using a protective tinted goggles. Thank you for your patient hearing.